He's a research scholar in the UCSF Claude Pepper Older Americans Independent Center, a National Palliative Care Research Center Cornfield Scholar, and a recipient of the National Institutes of Health GEMSTAR Research Award. We're also proud to say that he just was awarded the American Geriatric Society 2020 Health and Aging New Investigator Award. Dr. Coltwell's research focuses on the intersection of geriatrics and palliative care and efforts to understand and improve social connections of older adults at the end of life through clinical practice, health systems, and policy. So welcome, Carla and Ashwin. Before I turn it over to Carla, just a few housekeeping notes is that we will have a Q&A at the end of our sessions, and we'll take the questions from the chat box. So if you look at the bottom of the screen, there's a little icon that says chat, and you can just type in your questions. Be sure the questions are addressed to the panelists, and then we will go from there at the end. Carla, let's turn it over to you.
Great, thank you. So it is my pleasure to be here with all of you discussing the topic of loneliness and social isolation during COVID-19. Next slide. So we're going to start by talking a little bit about what the magnitude and prevalence is in loneliness and isolation, and really thinking about that, how we define loneliness and isolation and how we measure this actually really affects our research outcomes and how we think about this problem. Next slide. So the way I like to think about this is that loneliness and social isolation are actually distinct terms. And this is important to know because often what you'll see in both research articles and in the media is that these terms are used interchangeably. But it's actually really important to realize that they mean different things. They can overlap, as these circles suggest, but really they are distinct concepts. So in brief, and I'm going to go over these in detail, loneliness is a subjective assessment that social relationships are lacking, and social isolation is something that's more objective and related to the number of relationships that someone may have, either that's with family, with friends, or with the community. Next slide. So delving this into a little bit further, loneliness is the subjective feeling of being alone. And it is also something that is incredibly distressful, meaning that it is distressful because there are discrepancies between ideal relationships and perceived relationships. So what the relationships actually are versus what you want them to have. Next slide. Another way to think about this is actually, when you think about loneliness, there are many factors that actually go into why someone may feel lonely. And this is important because this is going to ultimately affect when we think about what can we do about loneliness and thinking about what specifically is going on right now during COVID-19. It's thinking about intrinsic factors. So what are factors unique to people? And that may be someone's personality. There's been a lot that's written about whether does being an extrovert or being an introvert actually affect loneliness? What is someone's psychological response to being alone? And what are someone's social group membership, which could be their self-identity as members of a specific ethnic and racial group, as members of a specific other group of identity. And then there's also factors extrinsically, so outside of the person, which will also affect loneliness. And that could be personal circumstances. And in this, I would think about living alone potentially, if that is something that is not desired. What is going on environmentally, which again, is related to what's going on right now with COVID-19 and the fact that people have to physically distance. And then there's certainly the things that regarding life events, traumas, and transitions, which I think is really important considering, thinking about end-of-life care and thinking about, again, traumatic events that are happening right now with COVID. Next slide. With all of this and with these definitions, it's important to think about there are many myths around loneliness that we should address. So first of all, specifically thinking about loneliness in older adults, it is not a normal part of aging. While it is common, that does not mean that that is quote unquote normal. The other myth is that it is synonymous with depression, and this is important because though you can have both loneliness and depression, they are not the same thing, and actually the majority of people who are lonely are not depressed. The other myth is that it would not occur if you live with others or have friends. You've certainly heard the expression that you feel lonely in a crowd, and this relates to this. Another myth is that it does not exist in married couples. And in fact, just this week, I saw someone in practice who was reporting extreme loneliness despite having a very supportive partner. And then the other myth is that it will go away if you join a social group. And this is also important as we think about interventions and what we do, because the answer is not always going to be just go join a social group. Next slide. In terms of prevalence rates, as I mentioned, while loneliness is common, it does not mean that it's normal. And what we've seen in some national studies is that the distribution of loneliness, which is shown on this graph, which is by age 20 to 90, kind of has an interesting curve in that, and actually the more recent data looking at people in their 20s and younger show probably higher rates. And what you see is some kind of peaking in the middle age group, and then potentially increasing in the later ages. What's interesting in the study that I conducted is that 43% of the population that I studied actually reported some degree of loneliness in those that were over 60. There's also a way to think about whether you're defining loneliness as chronically severe or if it's something that episodic. Another study in the United Kingdom really looked at the severity of loneliness as someone feeling always chronically lonely, and that prevalence rate is about 9%. So still pretty common in terms of how many people we see and why we consider this to be an important public health problem. Next slide. In contrast, returning to social isolation. So social isolation is really the complete or near complete lack of contact with society is a very broad way to look at it. But again, it's about the quantifiable number of relationships. So this is also something that right now during COVID, we're seeing that, the usual social structures and number of relationships that we have are changing because of the physical distancing we're having to do to protect the public health. Next slide. And in terms of prevalence rates for social isolation, some estimates, and this one is from AARP, suggest that nearly 1 in 5 older adults has some degree of social isolation. So what is going on with the research, and what do we actually know about the effects of loneliness and isolation on health? So I conducted a study in 2012, which was from a national representative study called the Health and Retirement Studies. We looked at over 1,600 people aged over 60. We followed people for 6 years, and we asked people if they were lonely using something called the UCLA 3-item questionnaire. And we classified people as lonely if they responded some of the time or often to any of these questions. What we were interested in learning was seeing if loneliness by itself actually affected people's health, specifically around death and functional activity. We chose function because in many of the patients that I see in practice, maintaining independence is one of the key things that people strive for. So I was really interested in understanding if this would have a correlation. So we looked at activities of daily living, which we define as things like taking care of your personal self. And then we looked at other mobility tasks such as climbing stairs, raising things above your head. Next slide. The variables that we examined here are a couple. So this is a usual, what we would call a table 1, which describes that we're really looking at all the things that usually would affect health, such as age, ethnicity, what the partnership status, socioeconomic measures, and living arrangements. And 2 key things I want to point out. What was fascinating here is that amongst people that were lonely, 62% of them were actually married. So again, this gets into these stereotypes that we have, showing that even if you're married, you can still be lonely. And the other one is that 26% of people lived alone, which again means that it was actually a smaller percentage of people that were living alone who were reported feeling lonely. So this helps us get into a little bit about the assumptions that we make and how we think about risk. Next slide. What we found in their results were the following, is that we actually found in people who reported feeling lonely, even after what we say in research, controlled for variables or removed things that often would explain these health differences, we found that there was a 59% increased risk of losing independence as measured by activities of daily living, and a 45% increased risk of death. So these were not insignificant findings, and these are highlighted here. Next slide. In summary, what the study concluded is that loneliness is common. It is an independent predictor of functional decline. It is also an independent predictor of death. And there's a lot to know. Go ahead, next slide. You're good, Ashwin. I want to go ahead and highlight that even though that is my research, what has been fascinating since that study was conducted is that there's been many more. Again, the things that worry many of my patients the most is the fear of losing cognition. And this is a study that actually really looked at cortical amyloid burden, which is the protein we see in Alzheimer's, and actually seeing a higher deposition or a higher amount of protein in the brain, which suggested Alzheimer's in people who were lonely individuals. Next slide. There's also additional studies that look at both social isolation and loneliness and all-cause mortality in men and women. What's interesting, the reason I'm pointing out all these studies is that what we'll find from the literature is that there are many studies that show both worsening health outcomes with both loneliness and isolation together, some of them just looking only at isolation, some of them looking at combinations. One of the challenges that we don't have a lot of time to get into today is that because of variations in how people define and measure loneliness and isolation, the results from some of these studies are a little bit hard to tease out because of these variabilities. But in this study, we found that mortality was higher, all-cause mortality was higher in isolated and lonely individuals. But interestingly, in this one specifically, loneliness by itself was not a risk factor. Next slide. Cardiovascular risk, again, one of the other things that is a big public health problem in terms of the number of deaths we see from cardiovascular disease. This study looked at specifically living alone. Living alone tends not to be a good proxy or a good estimation for social isolation because there's various levels of living alone in terms of is that by choice or is it something that's out of necessity and because there are no other options. So this is tricky, but again, what this highlights is that there's a lot here in terms of how do we measure social isolation, how do we measure loneliness, what does it mean to live alone, and when does that become a risk? Next slide. The potential mechanisms for all of this is actually, the research goes back decades. And what the underlying mechanism for all this is actually thought to be that when you are lonely, for example, and have this degree of distress, or when you're isolated with a fewer number of contacts, that there's an increased stress response in your body, which results in higher cortisol levels, and those things ultimately affect all of these different health outcomes. There's also some theories that suggest that there may be decreased sleep that could affect some of the health outcomes, decreased motor function, which really means how our muscles and our bodies moving in space and whether that can be related to why we lose independence. There's also some thoughts about if I'm lonely and if I don't have good social contacts, am I not as good at performing self-care, and am I not as good as engaging with the medical community? The other thought in a broad sense, putting this all together, is that all of this over time is thought to cause this wear and tear on our body. So if we translate this to COVID-19, what's challenging is that, and Ashwin is going to explain some of what we're seeing right now during this pandemic, but that we do not know how long we have to be undergoing this wear and tear of loneliness and isolation to have these downstream health effects. Next slide. So in summary, what we know is that the loneliness and isolation may be harmful at any age, but it is likely worse for older adults. And the reason being is that as older adults are reserved for coming back from any of these social or psychological or physical insults is much harder for us to come back with. And the research on this is very profound in terms of the number of health effects. As I indicated and just shared a few of the studies, worsen heart disease, worsen control of diabetes, poor sleep and increased depression, frailty and functional decline, potentially Alzheimer's dementia, increased mortality, and ultimately this also all results in higher healthcare costs. Next slide. And with that, I'm going to turn it over to Ashwin, who's going to talk to us a little bit more about what we're seeing specifically at the end of life and specifically during COVID.
Thanks, Carla. And thank you for having me today. So first I'm going to discuss how about at the end of life? How are people experiencing loneliness and social isolation? So this is a study that we're currently conducting, trying to understand levels of loneliness and social isolation among older adults approaching the end of life. This is a little bit of a busy slide, but on the right-hand side, you can see a graph showing the prevalence of loneliness and social isolation over time in the last 4 years of life. And the blue dots is loneliness, and the yellow dots is social isolation. What you can see is that over in these 6-month intervals, as people approach the last 6 months of life, levels of loneliness go up to about 80%. So about 4 in 5 older adults report regular feelings of loneliness. For social isolation, so again, minimal contact with the community, few household contacts, and little social interaction in the last years of life. The rates at around 4 years prior to death are around 16%. That nearly over, those rates more than double in the last 6 months of life to about 1 in 3 older adults. So it's quite common in the end of life to experience both loneliness and social isolation. We found that this is associated with worse quality of life. So lonely older adults in one study published in the Journal of the American Geriatric Society earlier this year found that lonely older adults were more likely to experience higher overall symptom burden, so pain, shortness of breath, being more tired, and they were more likely to use more aggressive hospital-related life support at the end of life. Now, this has been extremely relevant to all older adults during times of COVID-19, particularly people with serious illness or people who are approaching the last months or years of life and experiencing everything going on in the world right now. So here's a little bit of the media attention that's been placed on this. A New York Times article from Paula Spann closer to the beginning of the pandemic, just what older adults didn't need more isolation. So we were very interested in understanding how has the COVID-19 pandemic impacted people's social experiences during this time. You know, we've heard many media reports that nursing facilities are limiting visitors, grandparents are limited from visiting their grandchildren, that people overall haven't been able to maintain the types of social interactions that they typically do. We've also heard media reports of socially isolated older adults experiencing breakdowns in needed caregiver support, that they're having trouble obtaining food or medications, and that people are having trouble navigating technology-based alternatives to social interaction. So we were very interested in what's actually going on right now in our communities. So we conducted a study of 150 community dwelling older adults in San Francisco from 3 different sites. We surveyed people in our own UCSF geriatrics clinic, in Covia Senior Services, which is a social program that with substantial outreach to community dwelling older adults, as well as the Curry Senior Center, which is a senior center serving older adults in a historically underserved area of San Francisco, the Tenderloin neighborhood. We were fortunate to have several volunteer interviewers who helped us conduct this survey, and we conducted phone surveys of older adults both at the start of the pandemic and every 2 weeks to track how people were doing in terms of their psychological well-being, their social connections, and whether they were having key medical needs addressed. And this is an ongoing study since shelter-in-place orders in San Francisco have still been in effect. So who did we interview? So far, we've conducted about 309 total interviews of around 140 older adults in San Francisco. On average, people are 75 years old. And we have a fairly diverse group of people, including from a racial and ethnic standpoint. On the bar graph on the right-hand side, we can see some of the characteristics of individuals in our sample. So the majority of the sample was female. most people are living alone, about 2/3 of our sample. About 1/3 of our sample is married or lives with a partner. And several people, nearly 40% of the sample, have depression or anxiety. We specifically wanted to capture people who have self-reported hearing impairments or vision impairments, or people who have difficulty with typical activities in their daily life. So bathing, shopping, or difficulty accessing transportation. So this reflects what we typically see in many geriatrics clinics. So for loneliness, we asked whether people, we measured loneliness in 2 different ways. The first is we used the UCLA loneliness scale that Carla mentioned earlier, and we found that about 1/3 of our sample reported frequent feelings of loneliness. We also asked if people just felt worse in loneliness during the COVID-19 pandemic, shown on the left-hand side. And about 43% of our sample reported that their feelings of lack of companionship, feeling left out, or feeling isolated were worse due to COVID-19 social restrictions. We were interested in who are the people who are reporting worse loneliness. And so we conducted statistical analysis to find key clinical subgroups who were at risk of worsened loneliness, shown on the right-hand side here. We found that people who had prior medical diagnoses of depression, anxiety, and cancer had nearly 20 percentage point higher rates of loneliness, as did people with significant functional impairments. So things like bathing, shopping, or transportation, having difficulty in conducting those tasks on your own, those people had quite a bit of loneliness. We also took a look at trajectories of loneliness over time. And so this is a really busy figure showing just the diversity of individual experience. So on the left-hand side is the loneliness score on this y-axis. And on the x-axis is the days since shelter in place. And we tracked loneliness scores since starting shelter in place orders. So you can see some people had increases, some people declined, and some people didn't change at all. And so it's hard to make out a specific pattern, but we were able to differentiate 3 different groups that came out of all of this data. The first was individuals where loneliness worsened over time since the start of shelter in place orders. And so you can see on the right-hand side in the graph, these were individuals where loneliness got worse, the scores got higher, or they were reporting that their loneliness was worse. And here's an illustrative quote from one of our participants. She states, "This has been the hardest thing I've had to do in my entire life. The isolation has made my mental and physical health worse." The second pattern was people who felt loneliness was worse initially, but it improved over time. And I think we've seen this pretty frequently as well. People are able to adjust and cope with these new social changes. So on the right-hand side on this graph, you can see the loneliness reducing over time since shelter-in-place orders started. And here's a representative quote. So, "I do reach out to people when I feel lonely. I'm trying not to make a big deal out of it because I know it is temporary. I'm feeling better in the last 2 weeks because I am more informed and know what is going on due to the virus." And then there are a number of individuals who just have not been as affected by the shelter-in-place restrictions shown in the graph on the right. And here's a representative quote. So, "I have had more support during these times than before. I've learned more during this time about technology. I've had a chance to read more and to help other people through technology." And I think this is one of the things we've been seeing quite frequently is when people are able to navigate technology as an alternative to in-person social interaction, they've been able to cope a lot better during this time. So how about social isolation and obtaining help? So we asked individuals how they were communicating with their social contacts during COVID-19. On the graph on the right-hand side, on The x-axis down here, we asked about in-person, telephone, video, and internet interaction, and how frequently people were making use of these modes of communication. In-person communication was pretty infrequent. You can see that only 15% of people had daily in-person interaction. And telephone interaction was the most common. So about 40% had daily telephone communication, 30% had more than a few times per week. However, we found a pretty significant digital divide here, that video interactions were, the vast majority of our sample had minimal or no video interactions. 47% had none, 29% had just 1 to 2 times per week communicating over video, and 43% had minimal internet use. Now, we know that social isolation doesn't cause distress, but it can lead to unmet medical needs more downstream. So we identified several areas of unmet needs. The first was just being able to access telephone or video clinical visits. About 20% of our sample have not been able to do video clinical visits, even though they're interested. Nearly a third of our sample have experienced delayed or postponed medical procedures. Nearly all of our sample has reported difficulty obtaining medications, with 80% reporting a lot of difficulty. 1 in 5 older adults has worried about their food security, and 20 to 60% of people have not been able to find enough help for basic tasks at home. So I'll turn it back to Carla to go over some of the clinical implications and some of the next steps here.
Sorry, I was trying to unmute myself. Speaking of technology difficulties. So I love this quote because this will help us move into what is the role of our healthcare system and what is the role of public health. And I love this quote because it says, all doctors, or we can say all caregivers, all people working in healthcare, all providers soon learn that their patients consult them far less often for specific illnesses than because they are unhappy and seek relief from their loneliness and despair. I also like this quote because this is really what started me on this path to understanding this research, because as a trainee and someone studying medicine, I thought that there was something that we weren't capturing well in medicine and our interaction with our patients. And this is really what brought me to understand this topic a little bit more. Next slide. So I want to start with some key lessons here. So what we've learned, both from the research that has come before this and what we are seeing right now during the pandemic, is that many older adults are experiencing worsened loneliness, but this is not universal, as we saw from the different pathways. This means that we need to be careful with assuming who is lonely or is not lonely. So this means that what we need to be doing, either as people working in healthcare or people in the community and thinking about ourselves, our family, and our neighbor, is how do we ask about loneliness? So there are a couple different ways, but one of the most validated ways is what I mentioned, which is the 3-item loneliness questionnaire. When we're thinking about social isolation, there's a couple different methods also. For healthcare use specifically, the recommendation currently is the Berkman-Symes Social Network Index. So I just wanted to give you some of those names, so as ways that we can actually think about how to more formally evaluate for these two things. Next slide. The other thing that's important to think about, again, as we think about screening or evaluation or identification, is how do we think about this from a population perspective? So given what we know that this affects so many people, it's a good way to frame it in terms of what is primary prevention and what is secondary prevention. So primary prevention means identifying people who are at risk but aren't necessarily lonely or isolated yet. And when we know from some of the prior research is that women are at greater risk, people of lower socioeconomic status, older adults. Interestingly, there's new emergency literature about teenagers, LGBTQ adults, and then people with recent losses. When we think about secondary prevention, so these are people who, for example, that Ashwin and I may have already identified in our study, where they're already experiencing loneliness, and this helps us to think about what happens in the next phase of the pandemic, but how do we decrease the consequences for those who are lonely and or isolated? So this again requires some sort of screening and identification, and it also requires knowing what do we then do about it, and are there interventions that work? Next frame. I love my colleague Jeremy Nobel and E.A. Casey from AARP and Harvard, Dr. Nobel from Harvard and E.A. Casey from AARP really think about framing this in terms of a pyramid of vulnerability. So looking at who's at risk, and that's detecting this, who's already disconnecting, and this means how do we build awareness around this topic so the general public and all of us understand that this is an important public health condition. How do we educate? How do we identify and address risk? And how do we build resilience? This is where I think a lot about, again, framing this in terms of the pandemic. This is why we're having these types of talks now, because we need to build awareness and recognize that though we are having to physically distance ourselves because of the pandemic, we need to be careful that we're not doing this at the risk of our own health. And then the top of the pyramid are those that are already severely isolated. And so how do we do more individualized and intensive interventions? Next slide. So the second key lesson here again is for thinking again about the risk models. If individuals are screening positive for loneliness on using one of these screening tools, what is our responsibility then is to think about why people may be lonely, and then focus on the advice that you're giving them to those mechanisms. So this means that we can't have a one-size-fits-all approach. Examples of interventions, and I know that Helen Gow will go into a little bit into this, but it's thinking about if someone has difficulty in social situations, and that's more of a personal intrinsic thing, is psychotherapy actually the answer for loneliness and not a senior center, for example? Maybe it's someone who actually has good skills, but they just don't have the contacts that they need. And so a friendly visitor or a friendly phone call may be something that's needed, and that could be the Institute on Aging's friendship line. Maybe it could be that someone is suffering more because they don't have the actual support they need at home. And so maybe the answer is actually in-home support services, which is a Medicaid benefit, and I believe it's called something different in Oregon. It's also important to think about, are there medical conditions that could be worsening loneliness? In some patients and some people, it could be depression. We also know that there's increased risk of loneliness in people with pain, and there may be subsequent use of increased opioids. And there's also other things such as hearing impairment and visual impairment, which also affect loneliness. Senior centers, as I mentioned, is an option for some people. Sorry, my neighborhood has like fireworks this type of year, even though it's not July 4th. So I apologize for the noise in the background if you can hear it. So increasing opportunities for social interactions. Next slide. This is crazy. So the management of loneliness, as I mentioned in that slide, it's very complex. And so I think one of the key points here, again, is that we cannot have this one-size-fits-all approach. And so it's really thinking about, as we think about interventions and what can we do, again, whether it's your patients, whether it's your neighbors, whether it's the people you're volunteering for, is thinking, does someone need help with improving their social skills? Do they need increased social support? Do they need more opportunities for social interactions? Or this addressing maladaptive social cognition, which is a fancy term for saying, do they need better coping mechanisms to deal with some of these feelings? Next slide. Ultimately, the other way I like to think about this in terms of who is in someone's social network. So this can be something that relates to both isolation and loneliness, in the sense that for an individual, who makes up your social sphere? Do you have people in your family domain, work, volunteer? What's going on in your cognitive and emotional life, spirituality, friends, or are there other areas that actually help you feel more connected to others? Next slide. But what can also happen is, as you start to look at this, is thinking, are there things that are actually missing from this? Next slide. And are there things that we could actually be adding in? And I think what's interesting about this kind of dynamic is that I have seen some programs that actually help individuals really draw this out and think about, what is in my sphere of connections, and are there ways, am I someone who needs a lot of those different spheres to feel complete, Or do I need one or two? And it's really about the quality of each one of those that actually matters to me, that helps me feel more connected to others. The last key lesson, which is I think very relevant to our group here on this call, is asking people what they might think is a solution for their loneliness. And the reason I bring this up again is because often we have a tendency to assume what people want. So what's been going on right now with COVID, we see is that there's many assumptions being done for older adults saying like, you should not see anyone, you should not see your grandkids, but really it's more about a conversation. There is an opportunity to learn about what else is going on in the community and learning about interesting organizations that are here to support older adults who want that support. The AARP Connect to Effect website is one of those, and certainly thinking about what is going on in your area agencies on aging. Next slide. Number 4 is thinking about in people who are socially isolated, and this comes from our research that Ashwin and I are in the middle of doing, is thinking about the unmet needs that may be resulting. This is particularly pertinent right now during the pandemic, but this is certainly not exclusive to the pandemic. I think what the pandemic is highlighting is that there are times where older adults may be having unmet needs that we have not been aware of because we are not asking about that. So with technology, a focus is that it's not just providing the technology, but it's how do we facilitate and make it usable for some of our older adults where this may be a new thing. With food insecurity, are we actually asking about food security and connecting people? With medications, we were very shocked to see how many people were having difficulty accessing medication. So is that a gap in terms of knowing what's available? Or is it a digital divide also, since many delivery medication programs are online based? And then again, thinking about ADL support, so functional support, but this is a tricky thing because we've been so limited by the physical distancing. Next slide. I think this might be almost our last slide. I wanted to end this by saying that, all of what we're talking about today really relates ultimately to the National Academy of Sciences report on this topic, which came out in February, right as the pandemic was starting. And there are some key recommendations that have come out, which I hope we've touched on. So one is that though there is quite a bit of evidence on the health effects, we still need a more robust evidence base, and this includes making sure we're using appropriate definitions for loneliness and isolation and measurement and knowing what works. A second goal is really translating the current research that we have into healthcare practice. And that's why a lot of the work that Ashwin and I are doing on this current COVID pandemic, we really hope will actually help inform policy and how we're delivering healthcare. The third step is improving awareness, and this is where all of you on this call are so important to get the message out of the importance of this. Strengthening ongoing education and training, and this means for our trainees that are going into healthcare, and for anyone at any level, really, in terms of what does this actually mean. And then the last really important point is how do we strengthen and strengthening ties between the healthcare system and community-based networks and resources. So how do we minimize that divide that exists? We have a whole slew of people we'd like to thank. First of all the residents and study participants, and just listed a huge number of our volunteers. The benefits and downsides of the pandemic has been that many of our students are out of class. It's been great for us because they participated in research, but they're not in school, technically. So thank you, and with that, I'll turn it over to Helen.
Okay. Thanks, Ashwin and Carla, for that overview about loneliness and social isolation and the amazing work you're doing right now with COVID. So I'm going to recap some of the stuff that was presented in the National Academies of Sciences, a document that Carla just alluded to in February, as well as pull in some information about sort of general interventions that people can try. And I'm really trying to target this at an individual level rather than a health systems level. But to go back a little bit to what the National Academies has recommended, what they are advising is that interventions to address loneliness is targeted specifically to individuals who are lonely and socially isolated. As Carla mentioned, this is a sort of multifactorial approach. This is a key word that we use in geriatrics and palliative care all the time, that there are multiple inputs to someone having certain conditions, and that's certainly true with loneliness. And then you want to have the active participation of the older adult. So, just prescribing something to an older adult to do, or telling them that they need to go take part in a social group, doesn't necessarily address what they have needs for. Ideally, intervention should be based on a sound theoretical framework. However, the caveat is that unfortunately, there is so far just a little quality evidence on the available effectiveness of different interventions. And so I'll try to mention where evidence is available, but a lot of the interventions that I'm going to be recommending are partly just from creative thought as to what we can do for people who are suffering from loneliness. I want to bring up the campaign to end loneliness. For those of you who have connections in the UK, maybe you have heard of this. The UK actually has a national campaign to end loneliness, and you can go to their website listed here, which has a number of resources that are could be also useful to those of us in the States. The campaign to end loneliness has convened an expert panel to look at the issues that they need to address as they rolled out their campaign. And they sort of categorized interventions into four different sections. Foundation services, which is sort of their bread and butter of how do you reach individuals, how do you understand the nature of someone's loneliness, and how do you support lonely individuals. Direct interventions is, what are the menu of group and one-on-one activities that you have available, and allowing individuals to choose them. And then creating opportunities for individuals to develop new relationships or deepen the existing ones that they have. Gateway services are things that we need in every community, such as transportation, and as Carla mentioned, the technology, not just the actual devices, but internet access. And then structural enablers, so environmental factors, community development, volunteerism, and what is becoming an increasing advocacy point for many different fields, what's called age-friendly systems. So this encompasses age-friendly housing, age-friendly health systems, age-friendly communities in terms of outdoor access, et cetera. So some direct interventions that I'll describe later in this presentation are to really look at the different ways that direct interventions can help. So the 5 different areas might be changing cognition, and Carla mentioned this a little bit. So this is something where sometimes psychotherapy or cognitive behavioral therapy can be useful for, and I'll talk about that later in more detail. Social skills training. So does someone have the skills that they need to develop new relationships? Psychoeducation, which is helping someone understand what their mental health condition or loneliness is, what to expect from it, and how to problem solve around it. Supported socialization, so that might be the use of mentors or teachers, so to speak, to facilitate befriending. And then helping individuals to integrate into community groups. Indirect interventions are the things that everyone should think about because these factors can contribute to loneliness. So does someone have a vision impairment? Do they need hearing support? Many people who have dental issues and are embarrassed by how their dentition look may withdraw from society. And so getting bridges, dental care, dentures can be helpful for them. Treating urinary incontinence, because that's another medical issue that can cause people to withdraw from the community. And then giving people exercise prescriptions, because even though exercise prescriptions have a whole host of health benefits in terms of physical health, it also can aid in loneliness for individuals who have that aspect of their loneliness cause. So I'm going to sort of break down different interventions into a number of different sort of categorizations. Groups, as I mentioned, aren't for everyone, but there is value and evidence base for peer support groups. So things such as friendship enrichment programs, or support for common causes of isolation and loneliness. So for instance, bereavement groups through different hospice organizations, such as what Lumina provides, groups to support widowhood, and other types of isolation and loneliness causes. Physical activity forms such as silver sneakers, which is a Medicare Advantage benefit for many people who have certain Medicare Advantage plans. Even though this was designed primarily to help people with physical fitness, studies have shown that being involved with a silver sneakers program can reduce loneliness and the feeling of depression that may be related or not to physical health. Tai Chi was studied in an Asian study, and they assigned health ambassadors within a community to recruit people in their neighborhood who were socially isolated and who were feeling lonely to peer-to-peer relationships in the sort of guise of providing Tai Chi classes. And that study also showed improvements in loneliness. There are also a number of online forums and virtual communities that people can take part in. I was just speaking with one patient here in my area who found a tremendous community by getting involved in social justice with regards to immigration affairs in the United States, and getting involved in that community, and it's been entirely online, has helped her feel connected and feel a sense of purpose. So cognitive behavioral therapy, as we mentioned, so cognition can be a huge part of why someone may feel lonely. And what cognitive behavioral therapy or psychotherapy can do is to teach individuals to identify their own negative perceptions and potentially irrational beliefs which might impede their relationship building. It can help individuals reframe their thoughts about relationships and assumptions about others' views and expectations. And even if in-person cognitive behavioral therapy is not possible right now, doing online or virtual telehealth cognitive behavioral therapy can be equally successful. Mindfulness, which is another term of also saying meditation types of practices, can also be particularly useful for people who are experiencing loneliness. What mindfulness can do is to teach a person how to maintain an openness, patience, and acceptance, and it enables a person to view life situations in a non-judgmental way. So for instance, someone who's feeling lonely can get into a vicious cycle of feeling like they're not going out and trying to make friends, but they're afraid of going out because there's, whether it's COVID or fear of rejection, or feeling a sense of social threat. And it becomes this cycle where that self-criticism prevents them from going out, but then not going out makes them feel even more self-critical. So a study looking at a virtual smartphone-based training that only had a duration of 2 weeks found that that reduced daily loneliness among participants by 22% compared to the control group. I want to talk a little bit about a specific type of meditation practice, which is called, it's called a number of things: metta practice, mindful self-compassion, or loving kindness practice. Because what this practice, which was largely founded by Jack Kornfield and Sharon Salzberg in the United States, it helps people to really think about their connections with the people and the world around them. So it not only helps people to develop self-compassion for themselves, again, trying to break that cycle of self-criticism about not going out and making friends, but also helps them to recognize that their state is a human condition that many people feel, and that that by practicing loving kindness, you can actually extend your relationships to the world around you and the people around you. I'm going to sort of add my take on loving kindness practice, which is that we are now all wearing masks when we're going out. We're wearing masks when we have to come into contact people, whether it's healthcare providers or at the grocery store. And I think it's helpful, especially because people can't really see smiles anymore, is to try to be really effusive with your smile and be open with your whole body. And one of the recommendations through loving kindness practice is to thank people who you do come into contact with. So even if you are socially isolating and you are not going out of your home to do shopping, maybe you are getting everything by shipment and mail delivery, there is someone coming to your door to deliver your packages. And whether or not you meet them at the door with a mask, leaving a note of thanks for them, or extending thanks and gratitude to all of the people who make your life at home possible, your plumber, your electrician, your delivery person, your mailman, is a way to try to extend and recognize your connection with the world. And so with that, I say, be curious and engage the people around you rather than just saying thank you. You might want to consider sort of asking about, who they are, how their day is, if that's something that comes up in your interactions with them. So technology is a huge, wide field, which Ashwin mentioned, has helped connect people to one another despite shelter-in-place restrictions. The different categories of technology that were categorized in the National Academies document is social media or virtual communities, virtual realities, social robots and conversational agents, and video-mediated friendly visits. I think I saw on the chat incoming, there was a question about, can you comment on the use of social robots, such as what's used in Japan? And I actually deleted the slides I had on that because of time issues, but I will say that the studies have shown that social robots, such as the animated baby seal and animated dogs, robotic dogs, have been shown to improve people's sense of connection and reduce loneliness. And that, interestingly, those were studied not only in people who had cognitive impairment, but people who were also cognitively intact, that improved loneliness in those individuals. This is a small list of phone and online resources that you might consider trying. So Carla mentioned Institute on Aging's Friendship Line. This is based in the San Francisco Bay Area, but it is nationally available for individuals 60 and over, or those with disabilities who need someone to talk to. They are both a warm line and a hotline, so they take calls of any kind, including crisis. They will also make calls out to you if you would like. In Oregon, we have something very similar called the Oregon Senior Loneliness Line for individuals age 55 and over that was started, I believe, in Clackamas County, but is now available statewide. COVIA, which is one of the organizations that has worked with Carla and Ashwin on their COVID-based loneliness research, operates a couple of virtual community services. One is called Social Call. The other one is called Well Connected. Social Call is a similar phone-based resource for individuals who are homebound or isolated. And Well Connected is a tremendous, it used to be called Senior Center Without Walls, which is a sort of community center that is entirely phone and online based with a menu of activities and classes 365 days a year. There are similar models of Well Connected in local communities around the country. And so, I encourage people in your own communities to consider starting programs like this. So Virtual Senior Academy is based out of, I think, Pittsburgh, and then Self-Help's Virtual Senior Center is based out of Bronx, New York. I will say that these two programs, or Self-Help's Virtual Senior Center, does require a $60 a month subscription for those folks who are in the New York area, but they do provide grant-funded scholarships for people who are Holocaust survivors. So I think that these Virtual Senior Academy and Self-Help's Virtual Senior Center, where they recruit adults not only as participants, but also to be the mentors and the teachers and the guides in these classes, have enabled people to participate and engage with one another in a very active, assertive way. I'm now wanting to go to sort of things that you might be able to do if someone does not have internet or video conferencing, a computer-based smartphone access. So of course, routine telephone calls, letters, and cards, that goes without saying. Those have been widely published as recommendations during this time of sheltering in place. I also want to suggest that people consider recordable audio greeting cards. These you can get easily on Amazon, online, and you can record up to 2 minutes or sometimes even longer, depending on the length of the recording device in those cards. And those can be a nice way to send your voice to someone if they do not have phone access. Putting together picture and photo storyboards for a loved one as a way for them to connect with what's happening in your life. Putting together care packages for them. And then what I would call the shared experience package. So you might send someone a DVD, a package of microwave popcorn, and a drink that they can share at a given time that you can sort of experience together by telephone, or make music together. So you might make music and then send it to your loved one to sing to with something that you have composed, or what we call a tandem project. In a tandem project, you might look at this website, which is Art and Healing, and they have a whole bunch of sort of ideas that you can do. So perhaps you do an art project together, perhaps you knit and your loved one knits, and you start a scarf, you send it to your loved one, and they finish it off, or vice versa. So it could be a number of different arts and crafts related projects, or putting together storyboards and history books and life stories and memories. If you do have video conferencing capability, you might make and share meals together. You can look at this website, Pandemic 2020 Virtual Dinner Party Guide. You can do story time. So this bottom picture of the Olivia book is being read by Josh Gad, who was the voice of Olaf. Many people who know the Disney Frozen stories will recognize his voice as one of the characters. So you can use video conferencing as parents and grandparents to read stories virtually to grandchildren. There are multiplayer online puzzles and online game nights that people can participate in. I have a colleague who is an avid pianist, and he sends about 30 seconds of a 70s TV show theme song to a group of people about twice a week, and we're supposed to guess what the theme song is, and if we do, he sends us a virtual quarter. I do really bad because I don't know any of the 70s theme songs. Creative use of video conferencing can also include virtual book clubs. There are a number online, or you can develop one in your own community. Live performances. So this is where your children who are also sheltering in place and doing homeschooling might consider putting together musics and theatrics for loved ones who are in facilities or can't receive visitors. There are courses for meditation and mindfulness practice, which can be done together. And part of what is nice about these forums is that it allows someone to do it sort of with a virtual community, and many of these will have Q&As afterwards so that you don't have to feel like you're doing it in isolation. Same goes with virtual exercise classes. And then if you are wanting to venture to in-person engagement, what I would say about this COVID pandemic is that, yes, you can still see people. And the important things to remember is that based on what we know about transmission is that if you can maintain distance and wear masks, which is what most states are recommending, is that there are safe ways to see people and engage with people. So having, meeting with your neighbor across the street and you each stand on one side of the street. Yard meetups where you stay, 6 foot or more apart from one another and wear masks. Going for walks with other people so that you still have more direct opportunities to engage with someone else. Again, staying 6 foot apart and wearing a mask. It's really important to consider expanding your social pod. We don't know how long sheltering in place is going to last, but we know that the loneliness and health implications are only going to get worse the longer this goes on. And so, I'm a huge proponent of inviting people to expand what you consider your quarantining community by connecting with another family or other older adults, And as long as you know your partners well and know that you're all going to be maintaining social distance from other people, and you can safely increase your social pod so that you have more relationships. And then for people who are interested or have the opportunity to consider Seniors for Seniors pet adoption, having pets, as we know, can be extremely helpful for relationship and loneliness. I put in a little photo down here of myself with my face shot on my chest. This is something that Lumina is expanding, and it's been studied in different countries, both with Ebola and with other pandemics, where with the PPE that people have to wear, whether masks and such, especially for individuals who have vision impairment or dementia, not being able to see a face or to read lips can be extremely difficult for communication and for feeling safe. And so I encourage you, if you are going to be seeing a loved one who has dementia, who might be fearful, to consider putting a large-sized photo of yourself on your torso. So loved ones in facilities. This is a particularly personal issue that I feel very strongly about. Clearly the public health recommendations require us to be mindful of individuals who live in facilities, because there has been such a huge proportion of individuals who have been diagnosed with COVID and who have died from COVID who have been residents of facilities. I think most people know that window visits are sort of the next best option to seeing someone in person if you have a loved one who is fortunate to be on the ground floor. I think that it's really upon us to push facilities to bring someone who's not on the ground floor down to the ground floor and give them the opportunity for window visits if possible. And then to advocate, as things begin to open up, for outside visits, whether in courtyards or in front of a building, if people can keep appropriate distance and masks. I think that in the same way that we want to bring light and engagement with people in our social pods, for individuals who are restricted to their facilities, bringing performances right outside their window is one good way to try to reach people. And then as things open up, I really encourage people to adopt a neighbor or friend. So if you are visiting someone, a loved one, a family member in a facility, whether it's a window visit or you are fortunate enough to be able to see them in a courtyard, is to consider befriending other residents in a facility through window visits, or again, if allowed, through outdoor visits, because there are many individuals who don't have family or friends in the vicinity who are able to visit them, but they may be someone who is desperate for a friendly visitor. So I am going to talk a little bit about advocacy. Facility restrictions, exist for reasons to try to protect the people who live in them. But we also know that as the COVID epidemic drags on, we are already facing a second pandemic of loneliness and people who are dying because of this loneliness and neglect from prolonged isolation. And so, advocate and know what the rules are, what the federal and state rules for residents' rights. Nursing facilities are regulated by the Centers for Medicare and Medicaid Services. And currently the Centers for Medicare and Medicaid are operating a phased plan to allow nursing homes to slowly open if they meet certain criteria. Currently, Massachusetts, Indiana, North Dakota have formally opened to allow outside visits for nursing homes. And then residential and long-term care facilities, including group homes, are regulated at the state level. And so the oversight bodies have encouraged, but they have not been able to truly enforce virtual visit technology access for residents in facilities, as well as that the staffing has not been increased proportionally to help residents who are needing to be taken to windows or to be assisted with visit technology. And so I think this is where our role, especially for you as a loved one of someone in a facility, can be particularly salient at this time. In terms of working with facilities, I want to particularly emphasize, especially since I now work predominantly in a hospice setting, that the visitation for end-of-life stages, this has been variously interpreted by facilities, certainly within Oregon, and I know that this is the case in most states. Most people are interpreting visitation only for what we call active dying in the last hours and days of life, when most people are already obtunded and unable to engage with their loved ones. And so I encourage everyone to contact their legislators and their overseeing bodies to look at this issue, because again, we don't know how long this pandemic is going to go for. And we are restricting many people at the end of life from having the visitation and the interactions that they need to put closure on their lives. That said, I do recommend that people follow facility screening and prevention protocols. Our goal is to work with facilities, not against them. Take your visits outside and distance and mask and minimize your contact with facility surfaces. Keep safe distancing practices in all aspects of your life. So if you have a loved one in a facility, please be particularly mindful of who you are contacting and what you're doing in the rest of your life so that you can be safe when you go to see your loved one. If that facility is part of your social pod, as I mentioned before, stick to your pod and don't expand greatly beyond that, because the individuals in the facility are particularly vulnerable to transmission risk. Get to know your ombudsman. So in Oregon, of course, we have the Oregon Long-Term Care Ombudsman and the Residential Facility Ombuds, but every state has an ombudsman, and these are the individuals who help you advocate for the rights of your loved one in a facility. And then I've mentioned, the COVID and the pandemic and sheltering in place is the perfect time for advocacy. Speak up for those who can't. Your personal stories about how you have been impacted and how your loved one in the facility has been impacted are particularly powerful. So contact your legislators, contact your Department of Human Services, write them letters and meet with them virtually by Zoom or whatever technology they're using for teleconference, because your words change how the policies go into place as things open up or the second wave comes. And with that, I'll stop. I realize we sort of ran over. We don't have a hard stop at 6:15. So I know that Carla, Ashwin, and I are readily available to take questions, however long they go for. So I'm gonna stop my screen share and let's see. Let me scroll up here. Okay, so I'm gonna just start with a question, actually a couple questions. On this, I'm gonna direct to Carla and Ashwin. And the first question is, how does race and ethnicity change the loneliness data, or does it? And do we know anything about that?
So I'll start broadly and then see if Ashwin has things to add. But unfortunately, what's interesting or unfortunate is that the more we delve into the research, the more we realize that we don't know, and that the more we realize that diverse populations are often left out of or not counted in or not represented well in research. So there is a huge gap in this literature in terms of understanding a little bit more about the intricacies and how race and ethnicity play out in general. However, we do know some things in that we know that some subpopulations, for example, immigrants, particularly first-generation Americans also, but more specifically immigrants, when there are language barriers and where there may be a part of a community where they are a minority population, they are at greater risk for loneliness. That also creates some challenges in terms of intervention. So for example, in the Bay Area, we have a decent amount of resources for people who are Spanish speaking. However, I have had some patients from certain ethnic groups and linguistic groups where what they actually need after a careful assessment of their loneliness and isolation is increased socialization, but we literally cannot find a good group with people who speak the same language. So this is a huge area for us to continue to work on. And I think what's also really important right now, given what's going on across the country, is really keeping our eyes and ears open more in terms of some unspoken biases that we have in terms of what's available. The other thing I will note real quick is also regarding, there is not just a digital divide across age, but there's certainly across socioeconomic status. So in many of my patients, they would be willing to have technology to facilitate social engagement, but they really do not have the resources to have that. So when I presented, when I testified before Congress last week, one of the things that I really talked about was this whole thing about its access and it's how we're using technology, which is really important.
So there's also some great comments here, so I'll read some of them as well, which is that many people, when engaging on the telephone, do not speak slowly and distinctly to help people hear and understand them, and that this increases to someone's feelings of helplessness and loneliness. So thank you for that comment. Let's see. So another question.
Just if I can, I did see a question in the comments that kind of dovetails what I just answered about technology, which was about how do we actually have technology that is for older adults and what is our role? I think that is such a wonderful question. And again, there's two things I would say. I have seen a huge difference, exactly as the commenter noted, is that giving an iPad to an older adult who is not going to work for many people, because iPad was not designed for people in their 80s and 90s. We have piloted something called the GrandPad here in San Francisco. I speak of this only because that's the one pilot that we use, not because I'm paid by this company. I do research on it. But what I like about this company, and what I think what this company can help other companies do, is that they have older adults on their advisory panel. And these were designed specifically for older adults and address exactly what the writer was saying. It's the size of the buttons, it's the audio, it's the features that make technology really hard for older adults. It's not having multiple buttons that you can't get rid of. It's really having, what are the key things, which are, here's the telephone, here's video, here's the news, or whatever it is you want for that person. So it is, for all of us as consumers, as neighbors, as activists, there's a couple things we would do. The Senate Committee on Aging right now is very focused on technology. And again, they're really focused broadly on access and not thinking about these nuances. So write to the people, write to the senators on the Committee on Aging exactly about these topics, because they are listening right now. And this is where we can actually make an impact.
Yeah, so GrandPad, which Carla alluded to, is spelled like grandpa with a D at the end of it, in case you want to look it up yourself. So please talk about the compounded effect of grieving in a time of isolation.
Whew.
I guess I'll just note that, so whether or not you have had a loss of someone who has been supported by hospice, all Medicare certified hospices provide grief and bereavement support, regardless of whether, again, you had someone on a hospice's services. So I encourage you, wherever you are at, to reach out to your local hospices to seek out grief and bereavement support, because I think that that does compound feelings of loneliness, and it can be a particularly vulnerable and sensitive time when you have lost someone that you have been very close to.
I think to add to that, Helen, it's almost, what I've seen is a couple things. It's kind of for some people, it's almost reliving of the loss, because it's if you've lost someone recently, it's refocusing and realizing that you're alone again, for example. I've also heard about grief and loss in a different way, and what this has done in terms of triggering for some people post-traumatic stress disorder. We've heard some stories from actually Berkeley students who were previously incarcerated, and feeling that this physically distancing is remaking them relive what it was like to be in solitary confinement and in a cell. So I think, to your point, it's being aware of what resources are there, but recognizing how all of this can re-trigger some very difficult emotions and experiences in many of us.
So one question that came up is, what is the best way to reassure someone in memory care that you have not been able to visit them because the rules don't allow it?
Such good questions and hard topics. So I think that some of the examples that Helen gave in terms of sending cards, video cards, pictures, it has to be a lot more frequent contact. Ashwin and I have had this conversation with our colleague recently who's experiencing this with their parents, and it's been very hard. And so they're really having to up the number of contacts in other ways so that they don't feel that they're forgotten. It's hard to give a one solution because I think every person's experience in memory care is different in terms of their level of impairment and their level of retaining information. But this is where I think actively working with the staff at some of these communities to help build those connections is so important.
I will say that I have been dismayed to hear that there have been some facilities telling their residents that their loved one had to go away for a while. I think that is one thing we don't want to do, is to at least be straightforward, even if it's not understood what's happened. But again, saying that someone has just sort of gone away and disappeared for a while without telling them, and you have no idea how long this is going to last, can be particularly traumatic.
I would just add that this might be an opportunity where technology can play a role. I think there's been nursing facilities or assisted living facilities even in San Francisco that have conducted technology drives. So people, drop off their unused iPads or devices that are just laying around the home, and facilities find a way to use them, to use FaceTime or to find ways to have face-to-face interaction. So again, I think just re-emphasizing the point of working with local facilities to find creative solutions. I think people realize that this is tough. It's really disrupted communities, and they want to try to find solutions here.
Someone had a question about animal therapy, and I think animal therapy can be hugely beneficial to people, again, whom animals and pets can be a warm and positive thing. My personal feeling that
for people who like pets, right?
I'm a dog person, but I think that the thing to think about if you do have a therapy pet is think of your animal as an extension of your body and your hand. So you need to keep your animal hand washed. So if you're going to be taking a therapy pet to visit people, wash the dog, wash your cat, wash your animal before you take your animal to see someone who may have a higher risk of vulnerability. And then another question that came through was, can I hug my grandkids? How do I hug my grandchildren? When is the right time, and how do I go about doing that?
There's and perhaps Helen, we can look it up and share it on your guys' website. But there's a wonderful New York Times article last week about how to hug during COVID. I actually think that this is a really good opportunity to have these discussions, which can be as simple as how to hug, but also what does this mean for care, and what are someone's preferences should they get sick. So I've actually found that these conversations are an opening into advanced care planning in terms of, and I've had these conversations with my mom, who my husband and I chose to come stay with us for a period. But we had to have these very difficult conversations in terms of, if you are here and we're having to go to work, what does that mean for your health? If we hug, what does that mean? How will I feel as the child if I get my mom sick, and will I be able to deal with that guilt? And mom, what are your preferences if you do get sick? And so I think there's an important part of sharing the decision making, not making assumptions. And really, if you think about risk, it is prolonged contact, which is the biggest risk. So unless you're planning on holding your grandkid for 10 minutes, which hopefully, That's a tricky thing, but there are ways to mitigate the risk. And I think it's just having open conversations about what this means.
Yeah, I think another question that came up with, how does being the at-home caregiver of a family member with dementia affect loneliness and social isolation? And I think that question can be interpreted in two ways. One, of the dementia loved one being lonely and feeling isolated, as well as the caregiver feeling lonely and isolated. We know that there are higher rates of a number of mental health effects for caregivers who take care of a loved one or a family member. And certainly within this COVID pandemic, when you are having to socially isolate because of your loved one's risk, that carries a greater burden because of what you need to do in order to protect your loved one. So I do think that being an at-home caregiver is also an area where, as a community and society, we need to think about how do we reach out and support people who are in these roles. I think that everything, as Carla mentioned, comes down to risk and mitigating risk and what your willingness for risk is. So when we think about the social pod concept, I know many caregivers who have not left their house and are doing everything by shipment and mail order because of their fear of their loved one. At the same time, we have to understand that as part of your self-care, you need human connection, and it may be beyond the person that you're caring for. And so if you need to expand your social pod to someone else, a friend, another loved one, that is all okay. And it's all about how do we, for however long this pandemic lasts, how do we open ourselves up enough so that we can be safe, but also maintain our sanity and our well-being. Because we know that life is not just about getting an infection or not. That quality of life really comes down to how connected we feel and the purpose and the meaning that we have in our life. So this question, and this I think will be the last one we'll take before we close at 6:30. I'm interested in how mental health support and interventions interact with isolation. I've had internet issues, so you may have covered this already.
I think it depends on whether we're talking about isolation or loneliness, because I think the answers are going to be a little bit different. As I shared earlier, there can certainly be an overlap between loneliness and depression, and that they can coexist. There's not as much research that I'm aware of looking at other mental health diagnoses, but you can certainly postulate that there would be involvement. So there's a couple ways to look at it. Increased risk. There's also challenges, again, in terms of, especially right now during COVID, is access to mental health services. So if someone's loneliness is worsening because of untreated depression, and we know that there's a problem with mental health parity, then targeting both the depression and loneliness are going to be very challenging. There's also the risk that the isolation, in terms of really being physically isolated and not having enough context, is worsening mental health. So it's very tricky in terms of, I think it's thinking about access to mental health and mental health parity. And then it also gets into what Helen, both you and I talked about a little bit in terms of what is the framework for understanding intervention. So is this someone whose mental health and loneliness could benefit from cognitive behavioral therapy and techniques for resiliency and mindfulness, or is it something else? So it's nuanced, but certainly important to think about these together.
Any last words, Ashwin and Carla?
I would just say, thank you so much for giving us an opportunity to talk about this topic. We're really appreciative of Lumina Hospice, and I really liked the discussion, Helen, about advocacy. I think this is really such an important area to advocate for, and older adults particularly are underserved populations who we really need to sometimes be the voice to create change right now. So people are listening, so this is a great time to advocate.
I couldn't agree with you more. I think this is the right time, whether we like it or not. This is forcing very difficult conversations and bringing this to the forefront. And I think I'm particularly concerned based on what I've observed in my own patients and then from some of our research is the delays in medical care. And so there's two things here. So one, on the advocacy front, I've seen some assisted livings here in our area not even allow hospice and other home health agencies into assisted living, which is really concerning, which is why educating ourselves in advocacy is so important. And the second thing is advocacy in general, again, about reaching our vulnerable populations and making sure that we're not making these broad-based solutions that are going to be very difficult for our older and vulnerable patients to adopt.
With that, I'd like to thank Carla and Ashwin and everyone for joining us today. This webinar has been recorded, and you will get an email from Brooke, who will send out the link to that. We'll also send it out to other people who have had interest. But thank you so much, and go forth and conquer loneliness.
Mm-hmm.